wide variation. And similarly with the MOUD receipt rate, so this is conditional on receiving an OUD diagnosis, how many people are receiving medications, and this also appears to be generally increasing. Yes.
Back where you said the number of things covered, how close is that to like what are the total? What would be 100%? What's the total that's included?
Well, I think it depends on how you define it. We kind of just thought about like who's the highest. So the highest here would be two medications. So interestingly, nobody covers methadone during this time period, which is important since that is sort of like the oldest OUD treatment medication. But two of the plans cover both buprenorphine and injectable naltrexone. I think if we were thinking of 100%, it would have to include methadone. And it would probably also have to include like every kind of service. So there is, inpatient, residential, rehab, outpatient, intensive outpatient, detox, therapy. I think when we tried to figure out like what's possible, I think it's around 10, 11. But as a non-clinician, I feel like I don't want to totally hang my hat on that, but I will say like a number of them, like nobody covered methadone, and there's some other things that I think all of them cover inpatient and residential at some point, and there's just some movement around. But like one thing that we found is interesting is so like in this like least covered plan, so in the year where Aetna only covers two things, they just cover buprenorphine and residential treatment. And so like that doesn't leave a lot, like not everybody can afford to take time off work to do a residential treatment. And so you can kind of see by what they don't cover, like where those leave gaps to treatment. I mean, that basically means either you take a medication or kind of nothing unless you can do a residential. So we kind of thought about it that way, but that's a good point. We should think about like best case scenario. Okay, so I want to spend a little bit talking about this idea of quasi-random assignment into plans. Um, so the way that Kentucky assigns people to one of these 5 managed care plans is they have this algorithm that kind of works like a prize spinner, but it's on the computer. And for every month that people join, because we find that people join in pretty much equal numbers every month of the year. So the beginning of each month, they find out who qualifies and they run this spinner of like person A is in this plan, then B, and then C, and it kind of goes around like this. And so if it were only that, we would consider that random. However, we have also found through our analysis of the data that assignment seems to be somewhat dependent on like the geography of the state and the plan capacity. So while all plans are available in all counties, we do see uneven distribution of the number of enrollees by plan county. And so we think that there could be some load balancing happening there, or it could be based on how many providers are available, because there are strict ratios of how many enrollees you can have per provider per county. There's also this issue of family continuity. So if mom qualifies first for Medicaid and a year later the kids qualify, they will be put on her plan. And I do also, oh yeah, and then there's just sort of the load balancing of, they have these contracts with the state that kind of says the max number of people they can cover in a given year. And so we consider that to be kind of quasi-random assignment. I'm not going to show it today, but we do a lot of statistical tests to kind of suss out how close to random is this. When we look at the characteristics of enrollees, both in terms of OUD type risk factors and demographics and household income and languages spoken in the home, we find that it's almost perfectly balanced if you separate urban and rural. So if you look at all urban plans compared to all rural plans and all urban counties to all rural counties. But, so we feel good about it being close to random, but we do know that just basically the way that the algorithm works, it's not perfect. And also just one thing that is interesting to note here is that the rates that the state is reimbursing per enrollee are going to be different based off of urban and rural. So any plan operating in a urban county is going to get more money for each enrollee, but within that urbanicity level, all plans are reimbursed at the same rate. So our empirical approach here is we're going to use the two-stage least squares or instrumental variable approach. So what we are most interested in is thinking about how the comprehensiveness of the plan that they're assigned to is going to relate to their OUD outcomes. But because they have this option to change plans, we can't do that directly, so we have to do it through this instrumental variable approach. The reason why we wouldn't want to look at just their actual or long-term plan, the one that they could have selected, is because you can think of a scenario where somebody who has OUD risk factors is going to select a more generous plan for themselves. So through doing it this way, we can look at the impact of the assigned plan on the OUD outcomes. The first results I want to compare, we're going to kind of compare young adults to the overall adult population. So just starting with the overall adult population, it can be kind of hard to see the smaller numbers up here, and it's hard to think about because we're interpreting these like very small numbers in terms of the baseline of what the OUD diagnosis rate is. The results are pretty consistent whether we look at the uncontrolled or with the counting near fixed effects or fixed effects and covariates. We find on average a 1-unit increase in the number of things covered by the assigned plan corresponds to a 9.5% increase in the probability that they will be diagnosed with OUD. So that's a really big difference, and it's statistically significant at the 99% level. When we look at medications, we still find this really strong relationship, though of a slightly lower magnitude. So here we find that it's a 1-unit increase in the number of things covered corresponds to about a 8.4% increase in the probability of them receiving medications for OUD. We do these extensions to kind of think about these like risk groups, but we're gonna, for today's lecture, we're gonna look at the young adults. And so we actually find a larger magnitude than overall when we focus just on people aged 18 to 24. So here, the assigned a 1-unit increase in the generosity of the assigned plan in terms of like the number of things covered is going to be associated with an almost 13% increased likelihood of being diagnosed with OUD. And when we look at medications, it is not statistically significant as high. It's at about the 90% level. Fewer people in this age group are getting medications, period. So that might be one reason why it's a little bit weaker here. But we do find, some evidence that it might be impacted in a similar way. It is also a larger magnitude, but, it's only marginally significant. And you might wonder, like, why would this be? And so one thing that was interesting to me is thinking about, the one thing people can do if they are assigned to a plan that's not generous and they, have risk factors for OUD or they know that they have OUD is they can change plans. If this is the percentage of people staying in their assigned plan by age group, you can see here that the youngest adult age group, this 18 to 24, is less likely to change. And I would say this is not to scale, like it's a pretty small difference, but it does increase every age group year that people are a little bit more likely to change. So if this youngest age group is perhaps less savvy about insurance, haven't kind of figured it out yet, they're going to be less likely to change their plan. And I should have mentioned before, but the results that I'm showing today, we're only looking at newly qualifying people in their first year. And so this is just sort of within their first year. As you get older, you're much more likely to change your plan. Okay, so some discussion. So as we can see here, the Medicaid enrollees they're rarely changing plans from the one that they're assigned. Overall within the first year of qualifying for Medicaid, only about 5% of people change their plan, so it's pretty low. And we also are seeing that plan generosity, opioid use disorder diagnosis rates, and medication prescription rates are highly variable by plan. And then we find that more generous plan coverage or more comprehensive coverage is associated with higher rates of both diagnosis and treatment with medication. It was a little under 10% in the overall adult age group, but it's up to 13% in this young adult age group, um, and similar effects with MOUD. And so this kind of leads us to this conclusion that standard coverage of OUD-related medications and services could potentially increase rates of OUD detection and MOUD receipt. So we see some kind of, you might know where I'm going from here, but we see some policy implications here that could potentially really improve the treatment of OUD, and also the how equitable it is. So someone in the least generous plan, if we're just kind of looking descriptively comparing the least generous plan to the most generous plan, someone in the least generous plan is about half as likely to be diagnosed with OUD and receive MOUD than someone in the most comprehensive plan. And this is, the two plans are being paid the same amount by the state. They are, could be similar in a lot of other ways. But they are kind of offering this like wildly different coverage, and it's disproportionately impacting young adults, probably because they are less savvy about insurance and maybe just don't know as much about how to navigate that. And so we also found, I had to kind of compress this talk to be able to fit into like the wider presentation, but we have these additional results that also show that covering more things is also related with how fast diagnoses are. So plans that cover more, maybe there's just more interactions with the healthcare system, which is going to allow a diagnosis to happen faster. And we also see higher eventual MOUD take-up when plans offer more services, which we hypothesize is a result of offering a wider range of services and having more points of contact with the healthcare system. We calculate this back of the envelope calculation, which also shows that if all plans were to offer the most comprehensive coverage as defined by most comprehensive, like within this study, so 8 things, that the OUD diagnosis rate could be 13.7% higher, which would be equivalent to diagnosing about 9,000 more adults with OUD in Kentucky in 2018. And we know that this would disproportionately increase diagnoses for young adults in particular. So some limitations, as you start thinking about coverage and generosity and how plans are managing care, there are a lot of ways to quantify it. And so, as I mentioned before, this is our pilot, this is our first attempt, but we are working sort of now on our second paper and thinking about other ways that plans might manage access to care and treatment, like prior authorization, which we are incorporating in future papers, but it's not in this one. And also, there are some weaknesses with the Medicaid data, but it does cover every single Medicaid beneficiary, and there are some real strengths to studying it as well. I also say, a limitation of this methodology is it can't be used with adolescents because they, don't have really control over whether they qualify for Medicaid or if they can change their plan. And so that's why this is focusing more on young adults. But you could definitely make an argument where if a family had stronger coverage, that their child, if their child had OUD, that they would be more likely to receive diagnosis or treatment. So now I want to kind of bring both papers together and kind of think about what we can take from these and how they sort of interact. So a major takeaway is just that as opioid poisonings and OUD continues to rise among adolescents and young adults, we must find creative policy solutions. Our second paper, the second paper presented here, shows that potentially a federal response of mandating comprehensive Medicaid managed care coverage could be helpful to increase OUD diagnosis and MOUD take-up among the whole population, but potentially also disproportionately among adolescents and young adults. However, if you kind of think back to those early graphs and think back to the differential kind of motivators of opioid exposures in different ages, you can also think of making an argument for more localized approaches by state and by age group being necessary as well. Because I think in addition to, targeting and treating opioid use disorder. We also need to be targeting these underlying causes of opioid poisonings and of opioid use or exploration as well. And additional work must be done to understand the MOUD take-up gap between adolescents and young adults. So without having clinical expertise, it's hard for me to kind of think of reasons why, except outside of maybe bias or something, why 16 to 19 or 20-year-olds wouldn't be offered the same medication in the same rate. But I think more work needs to be done there for sure to understand that. So I want to just conclude by saying that hopefully I've made a strong argument today of why adolescents and young adults are uniquely impacted by opioid-related harms. And as a policy researcher, I think that policy and practice solutions must consider the unique causes of opioid-related harms and also, think of creative ways of how we can address this. Kind of wrapping back into the urgency of an earlier slide, we are still seeing increases in these harms, including poisonings and diagnosis of OUD, which indicates to me that more attention should be spent on this group. As I kind of move forward with my own work, I plan to think through how some creative approaches of how we can think about the relationship between managed care coverage and OUD diagnosis and treatment within adolescent group, given that they are kind of uniquely not the ones to choose their plans. And also I'm kind of starting some early work now about detecting early warning signs for substance use disorder in adolescents. So I appreciate any, questions or comments or feedback about sort of how to continue moving this forward. And I appreciate the time today. Thanks so much.
The green light is on, so is that better? Yeah, okay. Questions for Shelby? Yeah.
This might be the most unhelpful question, but I'm curious, were there any racial or ethnic differences where, Latinos or African Americans or Native Americans were you able to, I don't know if actually that data is even available through the data set that you acquired?
Yes. So unfortunately, we have some data, but it's so incomplete in both data sets that there's anywhere from 80 to, or I guess 70 to 80% of complete race variables per year. And so because we'd have to put such a large confidence interval, and because within that range, we were just worried about saying something that wasn't correct. So we don't feel that the data quality is there, but I do think it's really important for to be considering those things. But unfortunately, it's a limitation of these.
Just have a quick question about whether you were able to look at the data for the 5 or 8% of people who changed plans voluntarily, just to look at whether you did see significant differences in terms of their opioid use disorder diagnosis or anything like that.
Yeah, I'm glad you asked that. So yeah, we do actually look at that a little bit, and we find that the people who are changing plans are changing to more comprehensive plans, and that they do end up seeing sort of larger effects in terms of the results. So yeah, I think that's an important thing to say, is that at least the few people who are figuring that out are able to kind of help themselves that way. Thanks.
Thank you. Your discussion talked about the assignment of the policies as a spinning wheel.
Mm-hmm.
How did that spinning wheel get decided? Was that politicians' policy who made that decision?
So there are about, I think around 35 states use something like that to assign people to plans. In a lot of states, they give a period of choice before they do that assignment. but it just happens to be that in a handful of states, they kind of assign you first and then kind of give a period of choice. Um, so from I don't know. So I would say I don't know for sure, but I think just from like work I've done studying the text of other laws, it seems to be that once one state does something and they, either the politicians, there has been a lot of research showing that, assignment can save money and, managed care saves money. And so I kind of suspect that it's sort of a mixture of, politicians and policymakers seeing this opportunity to save money and then wanting it to be fair. And so one person says, we did a wheel, we think it's very fair. I don't know. So I guess I don't have a great answer except to say that I have seen, at least in cannabis laws, like that one state will kind of do something and they get some attention, and then other states kind of quickly jump on board. And I would say it's kind of a mixture of whether it's like the politician or the
I just was
policymaker.
wondering how they decided how it would make sense to just spin a wheel and put somebody in a plan, so.
I think they just thought it was random. I don't know. Yeah, that's a great question though. I'll have to look more into it because it would be interesting. There was a team of researchers at the Urban Institute who kind of studied Kentucky's transition to managed care and to assigning people to managed care. And so that's where my understanding of the wheel comes from. But I don't know that they say like why. So yeah, that's interesting. Thank you.
This was super interesting. Thank you, Shelby. I had a question about the first paper you presented. How do you decompose increased like poisonings from increased reporting of poisonings, given that people might be like more likely to be at home and potentially with a parent or somebody else who would be like more likely to report it?
Yeah, that's a great question. So what we did is, so we have, we only have data on those years for these substances. We have it also for like cannabis and alcohol, but there are annual poisoning reports done by the National Poisoning Data System, and they actually list like the total number of calls per substance per year. And so we just looked back and compared it because we kind of had the same thought of, maybe if they're just in the house, they're more likely to call, period. But we compared a few substances, like we looked at exposures to like household cleaners and then just call volume in general. And we saw that both of those were not affected by the pandemic. Meanwhile, opioids were. And so that's kind of what we see as different. But I would say that's, there's probably some more work we could do to increase the rigor. But that's what we've done so far. Thanks.
So I wonder if you might share, I'm a little biased here because I'm part of this study, but I think we had some interesting findings around coverage for services versus only coverage for medication-assisted therapy, so MOUD. So I wonder if you could just share that a little bit with the group and why that might be important.
Sure. Yeah. So I'll just put back. So I don't have those in here, but I can kind of draw some comparisons based off of what is here. So when we looked at the overall, these sort of are our main specification results. We looked at the number of, let me go back a little bit further. So we look at the total number of all things offered. So thinking back to those other graphs, like that anywhere from 2 to 8 per plan per year. And we look at how a 1 unit increase affects these results and this likelihood of diagnosis or treatment. But we had some, we started to wonder, like, how much is due to medication versus other services? And so we have some additional results where we essentially take out the medication from that total number, whether it's 1 in some plans or 2 in other plans, and we kind of recalibrate like the scale of what can be offered to only include services, and we've actually found like more significant results. So we found that for, without including medications, like a 1 unit increase in number of services covered is associated with, I think it was around 11% increase in OUD likelihood. And so That speaks to something that has been kind of understudied so far in the literature. So there's been a lot of emphasis on the importance of covering medication, but services are also still important, especially things like weekly check-ins or offering detox or offering therapy. And so, yeah, we're particularly excited about those pieces of the results just because they haven't really been covered very much in the literature yet, but we do find that they're still very important. Yes.
Feel, we're very big on
Yeah, I think just to clarify that we, but basically what we were able to do was control for the fact that all the plans covered buprenorphine. And so it was kind of a question of like, okay, if we keep that constant, that all the plans cover buprenorphine, but does different levels of service coverage make a difference? And it really does. And I agree, Harold, that what to us was so important because CMS, the federal government, requires through the Support Act that that's the one requirement around coverage they have is that the states and the plans have to cover medication-assisted therapy. Not necessarily all forms of medication-assisted therapy, but it was kind of a little experiment of like, just covering bup does, because I think a lot of people assume if you just get them on medication-assisted therapy, maybe services are not so important. And so I do think that surprised us at how significant it was that services really do matter, at least in Kentucky. So we're going to be looking at this more. Yeah.
Yeah, we're kind of, yeah, I think so too. And especially, this is now a few years ago. And so I think like medication has been increasingly losing stigma, but, there's a lot of organizations that provide in community substance use support, like Alcoholics Anonymous, that discourage the use of medication. So, I think it is really important to just offer patients a wide range of options and let them decide what feels best for them. So I think that is another conclusion we can make from just offering a wide variety of services and also just, including or increasing the number of contacts between providers and patients seems like is always going to be helpful. Yeah, thanks. So.
I just have a couple quick questions. Hopefully these are more like future thinking questions. But one is, do you have any sense of what kind of timeline we're on in terms of younger adolescents getting access to medication? And that may be outside of your wheelhouse. And then second, you talked a couple of times about the importance of, you used the word creative sort of approaches to increasing access for young people. And so do you personally have any ideas about what those creative approaches could include?
Yeah, so for the first one, I would say, I don't know, like it's a little bit, I think the clinical work I referenced was done after it was FDA approved for 16-year-olds, which happened in either 2001 or 2003. So it's been a long time that 16 plus have had access, and it still doesn't seem like take-up has increased very much. And so, yeah, I'm not sure if there's any like path to regulate it or to allow it for younger ages, though I do think that clinical work indicates that would be helpful. And then my ideas for creative approaches, let's see. So I think honestly, just providing more funding for things like nonprofits and local agencies that are doing the work, because one thing I found like particularly interesting just in the opioid space is that once legislatures kind of are able to pass money to the state level or to like sub-state level, a lot like each kind of community leaders or like people who are in recovery or physicians who are offering a lot of support services, they have those creative ideas. Like they kind of see what gaps need to be filled, whether it's through, like, so I just moved from Georgia not too long ago, and I had a colleague who was more in the in the space, and he was in recovery himself, and he worked with this organization that kind of provided like 2 tracks. So there was either like the medication or no medication track, and then they also would put like harm reduction backpacks together with like Narcan and like cards of who you can call to get buprenorphine, and they would like just distribute them to homeless encampments and kind of just make things available at so many different levels and at so many different on so many different like tracks, sort of, that it just provided a lot of choice. And they saw really fantastic results of that in like Athens, Georgia, where I was. So yeah, I think unfortunately, I think like the nature of my work makes me better at looking backward than looking forward, because so much of what we do is evaluate like how did what happened help. So I feel a little nervous, like kind of making suggestions for the future. Except I can say like what has helped is sort of that localized financial, making the money available on the local levels, and kind of quickly evaluating it and kind of figuring out what is working, what isn't, and kind of being willing to be flexible and shift. But I also think just screening. So since the opioid epidemic began, there has been an increase in screenings available. So like NISDA, one of the national organizations on substance use, has made a 3-minute screening tool, and it's even can be used like on the computer or on a tablet. And there's an increased use of that in doctors' offices, which I think just these little things that we can tweak and kind of getting a gauge for the population as well as we can, and not making a judgment based off of what somebody looks like when they show up in your office. Just kind of making these screening tools and kind of making it universal. Like they've been able to capture a lot of previously undetected cases. So yeah, but thank you. But curious to hear if anybody else has ideas too.
All right, well, I think we're coming to an end, but feel free to go up and have a conversation with Shelby. Thank you so much.
Yeah, thank you. Thank you guys so much.